A warm welcome to everybody joining us for the launch of the Unicef World AIDS Day 2020 report under the theme Reimagining a World for Pregnant Women, Children and Adolescents Living with HIV. We're meeting under very extraordinary times here around the world when many countries are reeling after the impact of the COVID-19 pandemic. And this pandemic has no doubt reversed some gains made over some 30 years in the battle against HIV and AIDS. And we are going to find out just how much damage and hopefully recovery we are dealing with through our panelists that we have today, whom I'm going to introduce in a very short while. And my name is Matuba Mahlachi. I'm a journalist based here in South Africa, in Pretoria, and I'm also an HIV/AIDS activist and an LGBTQ I'm basically a human rights activist, I'll say, but I've got more interest in HIV and AIDS issues happening here in South Africa and around the world. And I'm going to just go straight ahead and introduce our panelists who are joining us today. And I'm going to start right here with Dr. Chewelu, who's supposed to join us, but she's got another engagement at the moment, but she will join us very soon. She's the Unicef Global Chief of HIV and AIDS based in New York. And she'll be giving us the numbers and crunching all those numbers and telling us exactly what we see through the report that we are launching today. And there's also Dr. Betty Mirembe, who is the country director for Mothers to Mothers, an organization which is based in Uganda, doing some remarkable work and empowering women, children, and the youth in general. And we also have somebody young, I'm thinking younger than all of us here on the panel, Jonas Kamalov. She's a youth innovator, an influencer, and she is making a difference through the Unicef Innovation Lab based in Kazakhstan. And there will be some house rules for everybody that's joining us at the moment, and they include a reminder to all of you that we are recording this event, and for all your questions, please use the questions to the panelists, especially, please post them in the Q&A box and not the chat box. The chat box, though, you can use for any technical issues that you may encounter. But for questions to the panelists, there'll be time for some questions, Q&A session, where you can pose your questions to the panelists. Please use the Q&A box rather than the chat box. And now we're going to get a video from the executive director of UNICEF, Dr. Henrietta Fore, who has a message for us. And this message will actually outline what the report is all about and what needs to be done for the whole world to catch up with the path to the 2030 goal, which is eradicating AIDS altogether. And with the pandemic having happened, there have been some setbacks, but there's also some hope. But we're going to take a look at that video right now and hear what the executive director, Henrietta Fore, had to say. Let's take a listen.
We continue having a few technical issues. We will project the video shortly.
Well, technical issues, as you can hear, holding us back a bit, but we continue. The show goes on and it will continue until we have that video. Rike, my colleague, will let us know as soon as we have that video, because it's important to play that video because it sets the pace for everything that we are doing today. But if you missed the theme of this event, here it is. It's reimagining a world for pregnant women, children, and adolescents living with HIV. Now, there's no one better place on this panel than Dr. Betty Mirembe, who can tell us how women mobilize to empower children and young people. And this work is done through your organization, Dr. Betty Mirembe. You can tell us how you mobilize, and this work it's very important work in the fight against AIDS and HIV, your Mothers to Mothers. Could you please start by giving us an overview of what Mothers to Mothers does and how it has navigated COVID-19 pandemic to do its work in the fight against HIV. And we'll have a conversation as you speak. Some questions, I'm sure we're very curious because I've read about the work that you do, which is remarkable, and would like.
Thank you very much, Matuba, and I'm happy to be here to share not only a story, but a story for many women living with HIV and also programmers that are in different parts of the world. I will start off by just giving an overview of what Mothers to Mothers is. Mothers to Mothers is an organization that has been in operation for over 20 years. And it was started in Cape Town, South Africa in around 2001. And it was started mainly focusing on women living with HIV, pregnant women living with HIV, and aimed at supporting them through that process to ensure that they deliver an HIV-free child. And the work that we do in all our programs, we use what is called the mentor mother model. You probably have heard and read about it, but basically the model is one that allows us and enables us to pick and select a mother from those that have gone through a program like the PMTCT program, equip them through some education, deploy them at facilities and communities, and basically give them an opportunity to share their experiences, offer psychosocial support to the women that they are seeing at those clinics. It's a different thing for a health worker to speak to a mother, but it also adds a lot of strength and impact when a mother who has gone through a particular program is sharing her story. And that's what mothers, mentor mothers do across the different countries where we work. We currently work in 10 countries. And over the years, we've reached over 1 million women. Before I start, I just wanted to share a short story about Eva in Uganda. Eva is a woman living with HIV, and she's been working as a mentor mother for about 9 years with one of our sites in the east and central region of Uganda. Her story basically speaks about what she went through right at the point when the lockdowns were announced, and how she struggled to ensure that those that she had been working with could continue their treatment and also stay in care during that difficult time. On the 22nd of March this year, she woke up to the news that lockdown had been announced in Uganda. And so overnight, she could not access the facility where she was working because transport, both private and public, was significantly limited. And so she stayed at home with her family. But later that day, she started to hear and to receive calls and also receive visits from clients that she'd been working with at the facility who live within her community, asking her how they could access their ART now that transport was not available anymore. As you could probably imagine, some of the rural areas where these mothers work are quite a distance apart, so people could not easily walk to facilities. And so she quickly had to find out how she can support the clients that she'd been working with to access their treatment refills. You could notice that overnight, clients that were willing and even not willing became lost to follow up as a result of the announcement of the significant measures that were introduced due to the lockdown. So she quickly worked and coordinated with our central office to avail her transport and also seek permission. One benefit that we have as Mothers to Mothers with the facility and community placement of a number of these mentor mothers, they have access and have knowledge of where these clients live. And so because of those contacts, she was able to reach those clients and deliver medicines to those that had missed and were missing within the subsequent weeks. I believe that this may be a story for Eva, but it's true to many mothers living with HIV that woke up one day to all these significant lockdowns. And I think the theme for this year cannot be more appropriate. We are living under a different kind of scenario, And we probably need to reimagine what the life of all these people looks like and what it needs to look like in the subsequent periods. As you have already said, Matuba, the World AIDS Day event this year will be held in new ways and largely virtually, because it's been a difficult but also challenging year, particularly for children, adolescents, and pregnant women living with HIV. And I think the reimagining a resilient response for children, adolescents, and women living with HIV report could not have been more appropriate. It basically speaks about the fact that we all need to follow this reimagination and resilient response with strong action moving forward. And for the first time in over 30 years of the HIV response, we are all being globally slowed down by another disease, and our gains are beginning to be lost by a pandemic in our own backyard. It's time, I believe, for all of us, not only clients, but all of us that are involved in the HIV response, to be resilient at all levels, identify challenges, reimagine this world that we want all these mothers and children and adolescents to have, and action on that reimagined response. The end of AIDS, as you've said, and I think that we all are looking forward to by 2030, remains the goal despite the challenges of this year. We all believe it's achievable, but we probably are at a time and a situation where we need to redefine the roadmap in the face of the global pandemic. The strategies that have worked to get us to this point may not work to get us across the finish line. The data that will be shared and has been shared within this report shows that there have been quite a couple of stagnations at different points. The ART coverage for women, the treatment coverage for women living with HIV doubled from about 45% to about 8% between the years of 2010 to 2019. But when you look closely at the data, it shows that we only rose about 5% between 2014 to 2015. So we basically were making a rise of about 1% each year. And I think at this point, we all need to ask ourselves why, and identify the old and new time challenges, and develop new ways of winning and implement them speedily, as we have less time than we had before. We should identify what initiatives have enabled countries that have achieved the 85% to do that, and reimagine them for other countries, sustain them, is failing children living with HIV, and this is not acceptable. 88% of the children living with HIV are in sub-Saharan Africa, and it's clear that if we are to win globally, we should win in sub-Saharan Africa. And only 50% of these are on treatment, yet we have 85% of their mothers in our programs. We therefore need to close this gap, as well as that of early infant diagnosis, with our global EID coverage at about 60%. And this is significantly suboptimal. Data, as has been shared and will be shared in this report, tells us where the children are, and also allows us to focus in on a couple of countries where probably more than 50% of the children are living. And it's clear that the gains made in those countries like Uganda, Mozambique, South Africa, Tanzania, Nigeria, and Kenya will impact the global statistics significantly. COVID-19 has reduced clinic attendance at an estimated 10%, and we need to recover this and be able to go forward. So as I conclude, I think we must find and also refine those that we have lost. And community programs, just like ours, and like all the others that other implementers are working on, are more critical now than ever before. Because we know that everyone we are looking for is in the community. Because of the restrictions that have been brought around by COVID-19, virtual means of keeping connected need to be employed and scaled up. And we therefore need to keep focusing again on those ways that will allow us to be able to reach the goal of ending AIDS by 2030. And we need to stay strong. we need to have our governments and all partners standing alongside this response to be able and to ensure that we are able to achieve this goal that we have been working towards for the last couple of years. Thank you very much, Matuba.
You are on mute, Matuba.
My apologies. I'm so used to live TV with no mute and so forth. Thank you so much, Dr. Betty Mirembe. That was a very encouraging presentation you just made there, because with all the obstacles that we've seen that were ushered by COVID-19, there's a sense of hope in your presentation that we can still turn the tide against. I remember this was a theme for 2012 World AIDS Conference, turning the tide against AIDS. And I think the 2030 goal can still be achieved, but we need to get to the hows and when and so forth, and put the timelines to how we can still get on the path to the 2030 goal, which is eradicating AIDS. Without wasting any time, I'm so happy to see you, Dr. Chewe Luo. We introduced you in absentia, and we're so happy to see you that you've joined us. And now that Dr. Betty Mirembe has given us the human interest story on the affected communities, who also happen to be the most vulnerable members of communities, it's time now for you to please look at the numbers that represent these communities and how they affect them. And we're so happy. Like I said, I'm really happy to see you to do just that. You crunch those numbers for us and give a global perspective on where we are in the uphill battle to eradicate the AIDS pandemic.
No, thank you. But I just want to, first of all, thank Betty for the presentation that she's just made, not just from the perspective of, you know, the situation as we see it on the ground through the lens of the work that Mothers to Mothers does, but also to thank them for the important work that they are doing, especially in these times today of COVID-19. And we couldn't do what we do if we didn't have the community actors that we have working with us. So my presentation today is about reimagining a resilient HIV response for children and adolescents, pregnant women living with HIV. As we sit here today, we know that there's about 2.8 million children living with HIV, children and adolescents living with HIV. Out of that 2.8 million, 1.8 million are children, and most of these children would have acquired their infection through mother-to-child transmission. And we are seeing a growing population of children going into adolescence as we provide them with life-saving treatment and provide them with the care that they need. But we still have 1 million, we still have 380 children dying every day from HIV, children and adolescents, despite our efforts. So we must redouble our efforts to make sure that the 880 children that we're seeing every day infected with HIV, actually these infections can be stopped, and we have the tools to do that. So as we go into World AIDS Day, it's really to think about why is it that we have so many children and adolescents still getting infected, and then of those that infected, why is it that despite the life-saving treatments that we still have children that are dying of HIV. So I want to just show you that on the right hand or the left hand, we have the numbers of what we are talking about in terms of children infected or children that are dying. And on the other side, we actually have the percentages of how many children and mothers we are reaching with antiretroviral treatment. So I'll walk you through this, and it's very simple. So the red bars actually indicate the proportion of women today that have access to antiretroviral therapy. And you see that for 2019, 85% of mothers all over the world that are living with HIV are having access to antiretroviral treatment. What is even more exciting about this figure is that in the region that is most impacted, which is Eastern and Southern Africa, we're reaching up to 95%, which is the global target for elimination of mother-to-child transmission. So we're aiming to get to 95, and Eastern Southern Africa has already achieved that. And South Africa in particular also, if I can just mention that country out, and the number of countries in Southern Africa have reached 95% coverage. What that has translated to, if we look in this line here of new infections and go back to this part of the graph, is that today as we sit here, we have about 150,000 new infections happening in children because of the enormous progress that we've made with delivering antiretroviral treatment to pregnant women. When we look at the children, which is the blue bars, and in terms of their treatment access, so despite our efforts, we still, as I said, we still have about 1.8 million children living with HIV that need our treatment. And if we look at then those children, the 1.8 of the 2.8, when we add adolescents, how many of them are accessing treatment? There's a sobering picture there. And you can see the difference between the maternal access, mother access, and the child access. And we only have about 50%, 53% of children accessing treatment. And this is totally unacceptable, especially when we have a situation where mothers are receiving care, adults are receiving care, but children are falling behind. And so with that in mind, our progress in treating mothers and the reduction in new infections as we see it in the black line, the dotted line talks about the progress we've made with reducing mortality in children living with HIV. And we see a lot of progress there still. But if we can bump up access to treatment, if we can make sure that all mothers are getting antiretroviral treatment, we should be able to eliminate AIDS in children in the near future. And our target goal is 2030. Okay, so this slide just indicates what I've just said, which is basically the gap between maternal treatment and pediatric treatment. And you can see there that, you know, although we're making progress, that gap continues and it's not getting any smaller year after year. But I also want to mention, I think one of the critical concerns we have as we think about our path to elimination, our path to getting to 95% treatment access, both for mothers and children, you'll see there that the progress over the last 4 years has not been what we saw in the previous 4 years, which was 2012 to 2015. And that worries us. We are flatlining for maternal ART access, but we've also slowing down remarkably for treatment access in children. That slowing down is worrisome both for children and for mothers, especially in the context of COVID. And I just want to mention some of the data around COVID and what we are seeing. Our recent data through the UNAIDS monitoring partnership with Unicef and WHO, we are seeing that, in fact, you know, when it comes to testing children and also testing mothers, we're seeing that testing rates are really going down. And for children, the rate can be up to 50%. And we're also seeing that new initiations of treatment are also going down, and the rate can be up to 50% as well. So that's a little worrisome. But when it comes to treatment continuity for those that are already on treatment, we're not seeing the same drop. So for children, with only 50% of children accessing treatment, any drop in testing is a very worrisome picture. And I think we need to collectively look at how we make sure that there's treatment continuity, especially the fact that children need those need to go to those centers to get their HIV test, especially if they're infants. But we can't do home testing when it comes to older children, so we just need to do better on that. So moving on, the other concern that we have is just the variability in access. As I said, Eastern and Southern Africa is at 95%. So you'll see there that when we look at Africa overall, we're not doing too bad, 87%. We also have priority countries where we've said to ourselves, we must do better in these countries if we're going to draw down the global infection rates. And we're at 87% in the priority countries. The global picture I've already talked about. But what I wanted to come back to is the countries in the red. I mean, the regions in the red. West and Central Africa is the second burden country after East and Southern Africa. And you can see there that they're only at 57%. And then for East Asia and the Pacific, South Asia, Middle East and North Africa, these are countries where infections are highest in the most marginalized groups of people, women who engage in sex work, but also women that are engaged in drug use. And these are populations where there's very little attention to how these populations access services. And we've worked well with the networks in the community to make sure we provide the type of care that these populations need. But with diminishing funding, our ability to reach this population is also dwindling. So you can see the low coverage there, which is very, very worrisome. Next slide. And then if I go then to how are we doing in reduction of new infections by region, you see that the same, I mean, the pattern in terms of the countries in the red, and I have them here in the red, of concern is Middle East and North Africa, where there's an increase in new infections in children 0 to 14 of about 30%. And then you can see the reductions in the rest of the three regions that I mentioned. The range is from 18% to 37%. And you can see East and Southern Africa there that we are at 63% reduction. And so with this picture, we know that we're nowhere near getting to the global target of less than 20,000 infections by 2020. And I've already said we have about 150,000 new infections happening in children annually. And we have to get on top of these variations in countries to make sure that women can access, because this is an effective intervention and no child should be living with HIV today if we can do well in this mother-to-child transmission reduction. Next slide. This is a slide, finally, I just wanted to talk about prevention of HIV in adolescents and also young women. And this is a slide, again, that looks at the trends of what we are seeing in terms of reduction. I just want to say that we do have global targets for where we should be by 2020, and it's reflected there by at the end of the bar here. But when we look at where we are in terms of the picture, you'll see that for adolescent girls and young women, we've made some progress, and that reduction translates to about a 35% reduction. Where we need to be by 2020 is a 75% reduction, and you can see that we're very far from getting there. Similarly, for adolescent boys and young men, we've had some reduction, but not as great as we're seeing for young women, where there's more concerted action to make sure we reach them. A lot of these young men here are men from key populations. So it's young men that are engaged in sex with men. It's young men who are engaged in drug use. It's young men that are engaged in, young men that are engaged in drug use. So you can see here that, again, similar to what we see in the mother-to-child transmission, that we're not making inroads for that population, and where we need to be is down to 60,000 infection annually by 2020. So next slide. So my final slide is just really to reflect the fact that our epidemic is variable depending on where you are. Heterosexual transmission continues to be the main mode of transmission in Africa, but in other regions you will see that it's the gay men in Asia and the Pacific, and also Western and Central Africa is a combination of gay men and sex work. But then when you look at Eastern Europe and Central Asia, also Middle East and North Africa, you see that that's a drug use epidemic, although the other populations are still there. And this really means that we cannot end AIDS globally without actually addressing key populations in our regions. Next slide. So what are the key takeaways? So my takeaway message is that we need, with this type of picture now with COVID, we need urgent scale up of innovation and proven actions. For PMTCT, when we look at where we need to go to get to the last mile, we need to go beyond treatment. And what we are finding for EMTCT is that we have far too many new infections happening in pregnancy and far too many new infections happening during lactation in the mothers themselves. Unless we close off the tap in the mothers, we'll miss these mothers and they'll continue to infect their babies despite having good PMTCT programs in countries like Botswana, South Africa. This is an issue. The other issue with EMTCT, when I say we need to move beyond treatment, is the retention in care and making sure that women are not falling out of care once they are initiated on treatment. And we need to work double hard to make sure that we're reaching them, we're supporting them from where they are in the communities. We have this type of mentor programs that can help them navigate the health system for this lifelong treatment that they need, especially during pregnancy and lactation. We must empower adolescents with resources to access safe spaces for their protection, but also for personal growth and for confidence and development. We must keep communities at the heart of the response. As I said, we will not get there without communities. And to do this effectively, differentiating how we respond, focusing on the local context is also going to be very critical. And we must expand our use of different data sources to understand the micro landscape of HIV risk and also why certain populations are not accessing our services. And we must advocate for more conducive, non-discriminatory legal environment, especially for our key populations in the regions that I've talked about. Responding to the COVID-related service disruption is the future. We must rebuild back better to make sure that we can reach people from where they are despite our COVID-19 pandemic. Thank you very much. This is our World AIDS Day message, and I'm free to ask any questions that you might have.
Sure. Thank you so much, Dr. Chere Luo, for that presentation. And your apologies are totally understood and understandable because we're living in very unprecedented times where we have to meet in this way and not in the way we used to. So technical problems are prone to happen in gatherings like this one. But thank you so much for that presentation. And I picked up things that encouraged me because of maybe the community I belong to here in South Africa, or maybe somebody also watching here, because it's a very inclusive and detailed presentation you just made. Because if there's any parent or a transgender person that's seeing themselves in a research project like this, they feel seen. And these are the people who are in the fringes of society. And in the many books I've read on HIV and AIDS, people who are marginalized, people who are vulnerable are people like the transgender people, or even women who have children out of wedlock and they contract HIV. They will always have issues accessing health facilities in many countries. Even here in South Africa, people will be judged, why are you having children when you are not even married, and those kind of things. And those things make people feel they are not worthy of the public health facilities that are actually available to them. So your research speaks to what Dr. Betty Mirembe also talked about in the resilience that people have, but also I've seen in South Africa the resilience that some people do not have, that organizations like Unicef are working to reach out to. And so thank you so much for that one. But I want to ask you a question now, because I'm worried that I don't see any questions in the Q&A, and I want to urge everybody to put their questions there. The only question I have now is from Karabo Tebele, which we'll get to in a moment. But you are so hopeful, Dr. Luo, in reaching the target in 2030. What kind of resilience must we have for us to reach that goal? Because I'm seeing it's less than 10 years to 2030 in turning the tide against AIDS completely.
Yeah, we've learned some important lessons when it comes to HIV. I always say that as long as we recognize that what has got us here with the HIV response is the way in which we have engaged everybody in the response. HIV at some point became everybody's business because all of us were impacted in some way. But in terms of how countries and governments and all of us have worked with the networks of people living with HIV themselves, but also the communities that are highly impacted, has meant that we've always been asking, what's the best way to reach people? What's the best way to do this? And I can just say that the HIV response is the one response that has been able, first of all, to take health to the communities, to take health to the lowest units of care in every part of the world, because that was the only way we were going to deliver on the HIV response. What that means is that we have very good programs like the one Betty Merimbe works with, where we have very good community facility linkages and people themselves contributing and responding, those peer networks that we have in the community that have been very supportive of people themselves who are impacted to make sure they're able to navigate what is it they need to do. And they also can offer each other psychosocial support. So what I am saying is that the future for this is to recognize that probably the 4 walls in a hospital is not enough, and that we must build on the capacity and the resilience that we've built within communities, within the lowest health facilities, to make sure that these programs actually continue. That's one aspect. The second aspect is that we need to look at our policies and direction. Apart from just talking about the partnership with communities, we've also partnered very well with industry to continue to ask the question, what's the best way to deliver this? So one example that I want to talk about is the work that UNICEF has been doing on advancing diagnostics in children. Infant diagnosis has been very complicated. It requires sophisticated laboratories, equipment, and also sample transportation from the lowest unit to centralized or regional labs that have the capacity to do this. We tried to and address this through various modalities, including, could we put the blood on a filter paper, put it in the post office to get to that central lab in Johannesburg, for example. And we knew that was very difficult. Samples got lost, results never came back to the facility. And so we've been working on what we're calling point of care platforms that are very simplified. They're little boxes or machines that can be deployed to any place where there isn't a lab, and we can still get that test from a child. Those platforms need to be upscaled. So that's one aspect. So HIV has taught us that we have to find solutions that are adaptable to the population that we are serving. The third thing that I want to talk about is just the drug regimens and where we are with drugs, not just for children and treatment. We now have very good drugs that all governments should be adopting and making sure that children are transitioned to the most optimal regimen so that they survive and thrive. But we also have good drugs now that are coming through the pipe for prevention. So pre-exposure prophylaxis should be accessible to adolescent women and young women. It should be accessible to young key populations. Now we have injectable cabotegravir, which should be even easier to deliver to the most marginalized populations of our society. So I think we have a lot of hope in terms of what's coming through the pipe and the way we've worked in the past. We just need to make sure that COVID doesn't disrupt our focus. We need to bring the two things together so that we see how we can build back better, even in the context of COVID.
Thank you thank you so much for that. And I'm sure living in sub-Saharan South Africa, we all know somebody who died of AIDS, or we all have a testimony about HIV and AIDS and the lessons we've learned over the years. And I hope your hard work really pays off in about 10 years time when we reach that the year 2030. We're going to move on now, but I still have a lot of questions, even for you, Dr. Betty Mirembe, about your vulnerabilities that you deal with, about, because women are often treated as second-class citizens in most societies, and having an organization like yours that's empowering women and against such a pandemic like HIV and AIDS, I'm sure there are challenges that you want to talk about and that you want to overcome as well. So we'll get to that in the question and session. I'm still urging everybody. I see the Q&A box is filling up a bit. I've got some questions there, but I'm urging everybody to please put your questions in there. We'll have time for questions. We're going to go straight to the next item now on our program with Jonas Kamalov. And she's as I said, she's a youth innovator and influencer. And the youth are, as we all know, the most important people in any population, because those will be the people who carry us, hopefully, to the future. And the youth can be very complicated from our own. I just became not youth very quickly. I'm 37 now. I'm not youth anymore, but I am a young person. I know how young people can be very complicated. And in the world that we're living in, when there's innovation and so forth, people choose different things than they did 20 years ago. So, and people are more expressive than they used to. So you'll find people who we've labeled MSMs, or men who have sex with men, not necessarily identifying as being gay, and these are the part of the vulnerable groups among the youth. So I would like you to, Jonas, to please share with us your innovative ways of reaching out to the youth, especially those who struggle to get access to HIV screening and therapy.
Sure. Thank you, Mr. Masuba, for introducing me. I would like to say thank you so much for letting me be a part of this event. And thank you, Ms. Betty and Ms. Chewy, for sharing such invaluable insights that I found really interesting. I'm a youth activist, a child rights activist here in Kazakhstan, Almaty, and I've been involved in creating innovative solutions for children and teenagers living with HIV here in Kazakhstan. So I believe the awareness in the availability of healthcare services is still an issue in Kazakhstan, but as a young person, I think I can totally see that there is a lack of exposure to statistics related to infected people, and as well as those people themselves. In fact, I would say that we don't have much of those statistics at all. All we know is that throughout the last 10 years, the number of children and teenagers living with HIV in Kazakhstan has doubled, while annual HIV infections keep increasing at a steady rate. Well, I assume that young people living with HIV status, or the representatives or the LGBTQ community that are also representatives of such a very vulnerable group, they may keep their status in secret because there is that stigma, social stigma around that those patients, which isn't necessarily connected to the lack of knowledge among Kazakhstani community, but I would say, as I mentioned, more because of the lack of exposure that we're having. Often kids or adults can be discriminative or prejudiced towards young people. Although as a young person, I'm educated on how to protect myself from getting infected and have the tools and the accessibility of these tools, I wasn't educated on how to be able to create a friendly and a comfortable environment for those who feel vulnerable and hesitant about their status. And I wish that young people were more involved and thus more educated on how to give that moral support for those who need it. Speaking from my own experience, the reason why I became interested in this issue in the first place has arisen from my interest in innovation, particularly developing a smart pillbox with automated monitoring system for patients with chronic diseases, manage their treatment on time, has been my concern at first. Because usually people with chronic diseases often have very complex day-to-day regimen to follow, and that includes people with HIV too. So briefly, the work that I'm doing supports a smart pillbox that helps to people with chronic diseases connect with their loved ones through using a mobile application and let those people have real-time notifications that would help them monitor their treatment in real time. While developing my project and researching more about the subject, I think I became involved. And currently, I work with the Innovations Lab in Almaty, and we're working towards conducting a clinical research at local HIV and AIDS hospitals. And that, to me, is one of less obvious ways of letting young people like me to get involved in the subject, which means to let them create their own solutions on their own. So whether it's an app or a device like I did, or a form of an arts, or even like psychological help, or any other contribution that comes from passion to what you're doing, can be both engaging and beneficial to us young children and just young people to be involved and to help our peers tackle with what they're just encountering in their lives. Thank you.
Thank you so much. Thank you so much. Sounds like you got it in control there in Kazakhstan. I must admit, I've never spoke to anybody from Kazakhstan. So for me, I've always seen it on the map and I'm like, so today I feel so good. It's something on my bucket list.
Absolutely.
Yeah.
Very encouraging. Thanks, Jonas.
Thank you.
And we encourage you to do more. There are questions for all of you here, and there's one from, and this one I'll give to Dr. Cheweluo. The first one is Karabo Tebele. He's from South Africa. He works for Jakarta, a very popular radio station here in South Africa. And Karabo is asking, when did UNICEF engage with the South African government regarding the study of pregnant women, children, and adolescents living with HIV? And how is UNICEF going to get involved in advocating safer living standards for people with HIV in the SADC region, including South Africa, of course? And there's it's a very long question. Are you with me? Are you all with me?
Yes, so SADC, South Africa, okay.
And then he says there is a there's alarming femicide, the killing and raping of women and children is South Africa, and is UNICEF in South Africa, and is UNICEF having any programs that will be phased into the country to minimize the surge of women and children being killed? Yeah, that's the big talking point right now, the killing and maiming of children. But those are the questions for you. I think I'm going to confuse everybody if I read them all now. Let's go with you. Please bear in mind that we have run out of time. And I know in South Africa,
I'll be very quick. We do have a South Africa UNICEF office. That's one thing. It's a good thing. And I'll tell you that in the efforts that South Africa, and I talked about the strides that South Africa has made on mother-to-child transmission programs and where they are, UNICEF works very closely with your Department of Health in supporting that whole drive. And even as we think about the last mile for South Africa to get to elimination and to be certified, UNICEF has been working very closely with South Africa to look at their data, define which pockets of South Africa need more effort and more resources to get the job done, but also looking at populations that are missing out and to draw attention to what else we need to do, especially at the local level, to reach out to those populations. Similarly, we have a regional office, apart from South Africa UNICEF office, we have a regional office in Nairobi and also a regional office in Dakar for Western Central Africa. And those regional offices are very well aligned and they work very closely with SADC and other economic entities in Africa. And trust me, we do work with the HIV program within SADC, and we do draw attention to a lot of these things when ministerial meetings are happening. And so that's the second response. And around the violence against women and children in South Africa and what, and what is happening, again, through our efforts with the Department of Health and the National AIDS Council in South Africa, I mean, the whole South Africa has prioritized women, especially adolescent girls and young women, in their efforts, and with a lot of support from the government itself, but also I'm aware that the Global Fund also has quite a lot of resources that are going into, and violence is one of the pillars in the South African response. So we are all working towards getting to that point where there will be less violence against women, especially young women. But you know, it's a collective effort. And I think media can also do more in drawing attention to this, and we have to work better together.
Thank you so much. Thank you so much, Dr. There's another question by Karabo to Dilnaz, please. We have a challenge, he says, of young people being reckless and not interested into wider knowledge on HIV/AIDS, COVID-19 even, and also on same-sex relationships. How is Unicef planning to embark on such drives? Or maybe you can share what you've done around those issues. And the next question will be to Dr. Betty Mirembe about the vulnerability. Oh, my tongue is tied over there. But yeah, that. We're going to talk about just that. Please, Dilnaz, take it away.
Sure. Thank you so much for your question. I do think that this issue is very commonplace in the world that I'm living in today, especially in my community. And what I am doing and what I observe doing, UNICEF doing in my city or in my country is that, well, with the UNICEF Innovations Lab in Kazakhstan, me and Ruslan Maluta are currently working on brainstorming on creating an online platform that would help to raise awareness on different issues, including HIV, AIDS, and same-sex relationships. I think that such platform can be a very safe space for different people who are feeling vulnerable about sharing their status or anything about themselves. And I do think that such psychological and moral support in the first place is the most important thing that we need to learn to provide to those people. And more, I think when we are talking about COVID-19, there has been a lot of, the biggest challenge about COVID-19 has been letting young children to find the most reliable information that they can and not spreading false or fake information. And to do this, UNICEF Kazakhstan has hosted different online campaigns, and I've been among those volunteers, and we were very active in social media and posted different information on how to properly check a fact that you're reading, fact-checking masterclasses, along with other information on how to maintain just your mental health during COVID lockdown, and how to make sure that you can do or you can take up current or appropriate measures if you observe any symptoms of COVID on yourself.
Thank you. Thank you so much. Dr. Betty, I'm going to rush next to you and I'm going to refine my question because this is my question, because I think you're doing remarkable work through your organization, because I read a lot about it over the week. And you can't pour from an empty cup as a human being or as an organization. So I want to know, where do you draw your strength? Because sometimes there isn't political will in a country to help certain aspects of your work. And sometimes there's just not enough money to do certain things that you want to do. But so I would like to know, how do you move from strength to sustain Mothers to Mothers?
Thank you very much, Matuba, for the question. And as you said, your question is really where we draw the strength, but then you've also asked about the vulnerabilities of these women and how they actually keep up. With the first question, being able to see the changes and the results that come out of these women and their work as mentor mothers at facilities and communities is very, very encouraging. Seeing them from a client that came into the clinic to seek for care, being supported, trained, and also placed in a situation where she can offer support to another mother and get good results out of that. And also seeing them support their fellow women, being able to go through the program and have HIV-free children is one very thing that encourages not only us, but also them to know that they are contributing to community and they are being able to change lives and support the fellow women that they are working with. There are definitely challenges at family level. You know what the African context looks like. but within the very communities where they work and live and serve. First of all, I must say that women are selected from the communities where they live, and they are empowered and allowed to work within the same communities. So the communities gain a resource, and they are also able to see the change that this person has been able to achieve. There has been a lot of empowerment that comes out of the result of them being involved in this mentor mother model. We've seen women being able to change the livelihoods of their families as they are earning and as they also gain the status of frontline health workers. Apart from being a resource, we've seen them strongly remain advocates within the community. In certain communities, those women are asked to continue staying at those facilities and work and being supported by other programs. We are very appreciative of the partnerships that have existed between Mothers to Mothers and Unicef in several countries. But I must also add that because of those baseline supports in Malawi, Uganda, and South Africa, even when those programs come to the end, those mothers still stay at the facilities and continue to support the women that are coming through. And I think for us, being able to know that it's not a short-lived support that's being provided to the facility, we know that we are creating an opportunity for someone to be empowered, not only at the family level, but within the community. It keeps us going. And I must also add that we've moved beyond using the mentor mother model just for the PMTCT program. It's also moved to other programs. It's also moved to the adolescent programs. It's moved to the OVC programs. It's also moved to the disability programs.
Thank you so much, Dr. Betty Merenda, for that very detailed answer. I appreciate it. We've got a few more questions. We can go on until 10 past the hour, because there's a bit of interest in the Q&A box and that question. And I think this one will be taken by Dr. Chewe Luo. How will we ensure that the new injectables are available to poor communities? That is from Dorothy Mbori Ngacha.
Right. Thanks, Dorothy. She should be answering that question, but I'll try and attempt to answer it. I think this is the issue with what we are faced up with today, even as we think about COVID vaccine and how we're going to get it to people, especially with the temperatures that people are talking about, that we need to keep the vaccine in. But I think that, for UNICEF, just starting with our vaccination program and the extent to which we've been able to reach children everywhere, even where there was no fridge, tells us that even, where there's a will and even when something looks like difficult to do, we can get there. And I still remember when we're doing PMTCT at the beginnings, we had the same challenges. What are we going to do for the mothers, given the complexity of what we needed to do, test them and then give them drug in our facilities? What I want to say is that we have experience in driving new innovation, and I think it's about political will. We have to have that dialogue now with the governments to talk about adoption and who they're going to prioritize and where. The second is that when it comes to giving injections, we do know, even with the immunization programs in the remotest part, we still are able to give a measles vaccine. I think that will be part of the sort of thinking through the logistics of what it will take, where this will be happening. And I think communities themselves that are affected will help us think through what we need to do. But not being able to give an injection should not be an excuse for not acting, but it will take a collective action to think through what we'll need to put a good program in place that reaches people.
Thank you so much. I'm sure with that one. Now let's amplify the voice of the young people. That's you, Jonas. There's a question for you from Karabotsele from Jacaranda FM here in South Africa. He's asking, what is your take on social media and young people advocating for women, children living with HIV? I'm going to repeat that question. What is your take on social media and young people advocating for women and children living with HIV?
That question is directed to who? To Naz?
Yes.
Okay.
Definitely, personally, I definitely think that being able to share the information and to make sure that, especially young people like me, get that information and learn more about the HIV and vulnerable groups that are having HIV is extremely important. And as a children's rights advocate myself, I think it's also one of my roles to be able to share the information, especially for my peers. And that's for the sake of letting people to be involved in it, and to be involved in it, excluding just sharing the information or being educated on only the preventable measures of the HIV or on, and especially in Kazakhstan, I think I wish we could learn more about the statistics, or we could have that more information on the current rise of HIV on Kazakhstan, and especially the children. And I think that's currently what in Kazakhstan, I think the Kazakh Unicef lab is currently working towards. And that's definitely what I deem important right now.
Mm-hmm.
Awesome. Social media is quite, it's a double-edged sword, I call it, because it can be very dangerous and it can be very powerful and helpful for causes like HIV and AIDS and advocacy and so forth. But we've got another question, and it's from Ji Hong Yin. She represents the Science Talent Program of China, New York Academy of Sciences, and Society for Science and the Public. I'm sorry if I didn't pronounce your name correctly there, but they're asking, what measures have Kazakhstan taken to control the spreading of HIV? So you can share with us, Dilnaz, the most popular ways that your country has done to combat HIV, and plus what can teenagers do to engage in the movement advertising knowledge about HIV? That's the question there from her. I think that would be our last question, or no? And this one, I think between Dr. Liu and Dr. Mirembe, you can share this one, how to detect and control the spreading of HIV during a great pandemic like the one we're going through. I think I'll give you both a minute each, and then Dilnaz, you can have the 1 minute on your own.
Sure. Again, as I'm a youth aid representative currently, there are mainly like 5 ways that UNICEF is prioritizing on helping teenagers and children with HIV. And first, it's really helping them with psychosocial help, psychological or moral help to let those children and teenagers who are currently getting help so that we can maintain them and so that they're staying there and not quitting getting help. Next is definitely having universal and continuous access to anything that could help you to find different symptoms or to be able to get medical help. Third is the helping or curing, preventing any side effects or any side sicknesses that come with the disease. And fourth, it's definitely, I do think it's one of the most important ones, or the ones that fighting with the stigma and the moral dilemma, I think, that's going on with the Kazakhstan community and helping children and teenagers to be able to reveal their status as comfortably as possible. And finally, I think it's connected to more older teenagers. Those are the young adults. To help those young adults that haven't still gotten the medical help, to help them transfer to the safe space where they will be able to get that help so that they will be brave enough to seek help and find that help from the officials and medical healthcare representatives.
Thank you. I think Dr. Liu, you wanna go first?
No, I wanted Betty to go first and then I can end.
Dr. Mirembe, please take it away.
Thank you very much. And I think it's a pertinent question at this point in time, because we know that the pandemic will last time that we are all probably not aware of. So it's helpful for us to think about what ways we can continue implementing our programs even during this pandemic. I think there are things that we have done previously that can be of great help in this time. We've had what we've called differentiated service delivery models that are implemented at community level that allow us to decongest facilities. COVID-19 is asking us to do the same. So we need to find out a way that these differentiated service delivery models within the community can continue to be implemented in a safe way and allow us to test and continue to identify those that are HIV positive, and then be able to initiate them and put them on treatment. And the other thing that we need to notice is COVID-19 has allowed a lot of tests to be done. There's so many people being tested at borders and at different institutions. Are there ways that we can couple HIV testing with that massive testing that is happening under COVID? I think there is an opportunity. COVID-19 is bringing people that routinely wouldn't be tested or wouldn't be coming to facilities are showing up at facilities, and we need to hinge on some of those benefits and ride along as far as our testing and identification is concerned. And lastly, we have a unique opportunity with COVID-19. Clients stay either in quarantine or in isolation for about 14 days or more. What can we do as HIV programmers during that period? Are there messagings? Are there opportunities for testing that we can avail to them? For example, in Uganda, there are many centers that have been set up and people stay there for 14 days or even sometimes longer. And we can hinge onto that and be able to put some testing and some programs in place within that time, as opposed to waiting for them to recover and make their way to a facility probably 2 months or 3 months later. We need to look at the opportunities that are availed through this COVID-19. And then the other thing that's happening is that a lot of this testing is actually happening at very highly certified labs that also do the HIV testing and EID tests in the country. So there is room for us to create some synergies, and we just need to be open and use the community and also use all the other platforms as much as possible.
Right, thank you so much, Dr. Mirembe. Dr. Leo, please.
Yes, I think she said it all. I just wanted to actually add that making sure that the people that are already on treatment are maintained on treatment is part of the solution. We know that with the movement of undetectable equals uninfectious, U equals U, is very, very important. We cannot afford to get people to drop off care and get the viral rebound and then start infecting others. So we need to make sure that we are linking up to these people. We can use social media. We can use other ways of linking up virtually to make sure that they stay connected and they're getting their pills. We are promoting multi-month prescribing to make sure that people have access to their meds. And I think governments have done well in adopting these measures. Misinformation and some people are just falling out of care because they are scared, because of lockdowns and what they've heard. And we need to make sure that we are collectively talking about how people can protect themselves, making sure that that information reaches people who are most impacted by HIV, but also as we do COVID, making sure that we have some standardized messaging around people's fears and concerns, and including where they can access services. And I think the innovations around making sure that we are getting services to the people rather than people coming to us is what we'll need to do for the future. And all these tools are available. It's just about making sure we do them. But thank you. This has been a very interactive conversation.
It's amazing. I hope my colleagues Petty and Enrique won't strangle me for this, because there's a fantastic question that just came through from Aaron Weintraub. And I think, Dr. Liu, you'd be best placed to answer this one. And it says, specifically regarding the Middle Eastern and North African countries and their uptick in cases, how much can these cases be attributed to political shifts in some countries in the region? Also, how much does political stigma regarding AIDS deter organizations like Unicef properly address the needs of individuals living with the virus? I think it's a beautiful question.
Yeah, it is a beautiful question. And that's why if in my slides, I highlighted the fact that we tend to focus on Africa and it's a very different epidemic. But when you go outside Africa, we're having to deal with populations that are highly stigmatized, discriminated against, and marginalized, even as we deliver health services. And if you remember one of my slides, I talked about it's about MSM, but it's also about drug use in that region. And so you can already see that these are populations that are going to have a lot of difficulties, even after they access care. Retention in care is a problem. So hello, I don't know what's happening. Yeah, so I agree. It's both political, but it's political, but it's also the way we deliver services and whether we have enough resources to reach out to these populations in a way that is meaningful to them. So thank you.
Thank you so much. Thank you so much for that. And thank you for all the questions that have been coming through. All the media people listening in or watching this event, please remember that if you want one-on-one interviews with our panelists, please contact Patsy or Sarah for those one-on-one interviews. I think that will give you, because I know journalists, we all want to play to the agenda in our respective countries, and I'm sure you have questions that will work well with the agenda setting that you're trying to do in your different countries. But to Dr. Betty Mirembe, Dr. Chewe Luo, Jonas Kamalov, thank you so much, my great panelists. You really made my work so much easier. It was learning
Young people are
resilient. We are resilient. While COVID-19 has made it harder for many of us to go about our daily lives,
including getting the services and the support we need, we are resilient and innovative.
We are strong.
And yet, when it comes to HIV, when it comes to keeping us safe and healthy, we still have progress to be made.
Not everyone knows this, but the tools to end AIDS among young people like us exist.
These innovations are not reaching those of us who need them the most.
It might seem hard to believe, even though the number of new infections among us is declining.
Still, in 2020, half of the children and adolescents living with HIV still do not have access to the HIV treatment so desperately needed. So, what is the way out?
What is the answer?
We believe that when we are supported
by non-punitive policies and measures,
inclusive programs and non-stigmatizing care and respect and empower us, we can make real change.
How do we know this? In 2020, we have seen prevention and treatment services like virtual peer education for marginalized young people, prevention consultations via WhatsApp, distance mental health support, trainings via mobile phones and WhatsApp, COVID-19 related support via Unicef's U-Report, creation of animated videos telling us how to stay healthy during lockdown, prevention programming with popular radio stations,
and click, like, and share a series of films and guide on mental health, cyberbullying, and HIV. And the impact has been immeasurable.
We are asking you and you,
our partners, our friends, our neighbors,
to join us in reimagining HIV prevention for a post-COVID world.
Together, we can.
And we will build back better for our generation.
For our generation, for me.
For me. For me.
And for me.
For me.
Those are very familiar accents there. It was produced here in South Africa by very young kids, very impressive. And I think that's the end of our show. Thank you so much, everybody, for joining us. I really appreciate it. And I hope to link up with you in conferences post this COVID-19. Hopefully it ends very soon, or we meet again on these platforms. Goodbye.
Yeah, okay. Bye. Bye-bye. Thank you, everyone.